Hello, good afternoon. I am Dr. Bhavesh Vajifdar, cardiologist at Lilavati Hospital, Mumbai. And today we have the opportunity of discussing with some stalwarts cardiologists from Delhi and Mumbai. We have Dr. Anil Dhall from Delhi, and we have with me Dr. Haresh Mehta from Mumbai and Dr. Sandip Rane from Mumbai. And today we are going to discuss on the very important and yet very often neglected topic of iron deficiency in heart failure. So I think we start off by asking Dr. Sandip Rane, sir, how common is iron deficiency seen in patients with heart failure?
Actually, as you rightly said, it's one of the most neglected topics. Iron deficiency, in fact, the incidence is pretty high, and it ranges between 45% to 56%. It is that high.
Wow.
Yeah.
So, is it possible to have iron deficiency and no anemia also?
Yes, in fact, yes, very much so. You can have a normal hemoglobin and iron deficiency, or the other way is a low hemoglobin and a low
Of course, that's
iron.
common.
Yeah.
So, how do we diagnose iron deficiency then?
I think for iron deficiency diagnosing, you need to have certain markers.
Okay.
And the most important is ferritin and transferrin.
Okay.
Yeah. If the ferritin levels, and for an absolute level of less than 100 micrograms per liter, that is an absolute deficiency of iron. Or if ferritin levels between the relative ferritin deficiency, if it ranges between 100 to 300, with a transferrin saturation which is less than 20%.
Okay. So generally these are a little more stricter criteria for heart failure as compared to a normal non-heart failure patient. Is that true, Dr. Dhall?
So we've got to understand this a little better. So there are a variety of reasons why patients who have heart failure develop anemia or develop iron deficiency. And what is very clear is that sometimes the laboratories give us a normal reference range of ferritin. Actually, that does not apply to these chronic conditions at all, because we've assessed that we can assess various parameters, like Dr. Rane has said. You can assess transferrin saturation, you can assess ferritin. People have also done studies with assessing hepcidin, which is actually the rate controller for the entire iron metabolism. And they found that the easiest way to do it is to measure ferritin and transferrin saturation. Normally, people can have, a normal person who is not in heart failure, up to a 20 of ferritin would be acceptable. But in a patient with heart failure, like Dr. Rane said, we look at anything below 300 we are suspicious, anything below 100 we know has got an absolute deficiency, and between 100 and 300 we also add the transferrin saturation, and if the transferrin saturation is less than 20%, then we know that we have a situation at hand which is of iron deficiency, and by supplementing iron we can hope to have a window of opportunity by which we can benefit our patients.
So, Haresh, tell me, do every patient with heart failure which come to your clinic, do you do these tests for all of them? And are there some group of patients where we have to be more careful, or does it apply to?
Up to some time back, probably we would not do it for most of our patients. We would just do the CBC, and if you find it okay, you would leave it. Like Sandip told you, suppose you find a hemoglobin of 12 in a lady, and you may say, oh, that's fine. But now I generally tend to do iron studies in almost all my heart failure patients. With personal experience, we have found that the moment you replenish their iron, their hospitalizations are going down. So as a rule, now I do it as a routine. Unless it's like 14, 15 hemoglobin, then I may not do it.
So, Dr. Sandip, patients with near normal hemoglobin and low iron deficiency, what are the symptoms? Do they also have, are they more symptomatic?
Yeah, in fact, it's surprising that you can have a normal hemoglobin and yet you can have low iron markers. And these people generally would have reduced exercise tolerance, they would have easy fatigability, lack of cognition, a lot of cognition problems. So these are very subtle symptoms which would come up when you have a normal hemoglobin and lower ferritin levels.
Right. So how does one calculate what is the deficiency of iron and how much iron should be given? Dr. Dhall, can you?
And that's a very complex issue. See, we used to use something called the Ganzani's formula, and that was kind of standard of care. I don't know when you were an undergraduate, but I know when I was an undergraduate, it was a labor to calculate iron deficit, especially in pregnant women, because the whole idea was to kind of build iron stores, and so that by term they would have, close to normal iron. But now we know that in a person who is, say, 50 to 75 kilos and who's got heart failure and who's got defined iron deficiency by the criteria, we know that he's going to have 1,000 to 1,500 milligram deficit of iron stores. So we can replace it, and we don't have to go for any tedious calculations. You don't have to use the Ganzani formula. You just know that between 1,000 to 2,000 milligram is the rough iron deficiency, and if we can address it, we'll be better off.
Right. So Haresh, it's very easy to give somebody iron, oral iron, like if you see almost every pregnant woman is prescribed oral iron. Then why not in heart failure? Why do people say that oral iron doesn't work well in heart failure patients?
So in heart failure patient, in addition to being heart failure, they also have mucosal edema. And because of that, the iron absorption is erratic or may not happen. In fact, one of the studies showed that if you give oral iron, it almost, especially if the ferritin is below 100, it almost never gets the ferritin up. So they had a controlled trial versus oral versus IV, and they clearly found that the transferrin saturation didn't rise, the ferritin didn't rise as much. So that's where we started hunting for parenteral iron for such patients.
Right. So when we talk of parenteral iron, when you must have been an intern, I'm sure you must have been given intramuscular iron injections to all the pregnant women which used to attend the ANCs. So what are the problems and why is it out of favor now?
Oh, I think if you're looking at parenteral, especially the intramuscular, I think it's a very painful injection, and I wouldn't like to take it myself. Forget giving it to the patients. Right. Plus, the earlier iron preparations, they used to have a lot of adverse reactions. Whereas the newer preparation, that is ferric carboxymalate, it doesn't have, or the incidence of reaction is very, very minimal. Plus, you give it intravenously, you can infuse it faster and can build up the iron stores very fast.
Right. So you mean to say the newer ones like carboxymaltose, ferric carboxymaltose are very safe and they have less side effects. So can they be given in an outpatient, or do the patient has to be admitted to give this?
No, you can give it as a daycare procedure. The patient comes down in the morning, you give it, you can observe the patient for a few hours and then you can send him back maybe.
Right. What is your practice, Dr. Dhall?
So firstly, I'll just like to add to what Haresh has said, that we must understand that if we look at the pathophysiology, these patients who've got heart failure and iron deficiency have actually got a hepcidin block.
Right.
So even by giving oral iron, not only will you have to spend 6 months of giving oral iron, but even if it gets absorbed, firstly, as Haresh said, it will not get absorbed. Even if it gets absorbed, it's not going to impact, because the answer lies, we have to bypass the hepcidin. And the only way to bypass the hepcidin is by delivering ferritin itself.
Right.
Number one. Now, so and there was a very good trial called the Iron Out study, which actually opened everybody's eyes, because it showed that oral iron did nothing to benefit these patients. And when we look at whether the benefit is only because of iron or the benefit is because of any which way raising hemoglobin, we know giving blood transfusions is effective, and we use it acutely, but it has its own range of side effects. Giving erythropoietin or erythropoietin substitutes is effective, but it leads to increased thromboembolic events. So IV iron today in heart failure is become kind of standard of care. And in my practice, I don't even admit them in daycare.
True.
I kind of, because it's a 15-minute infusion, at best, if I want to be careful, if my nursing staff wants to be careful, extend it to 1 hour. And that's
so when you say 15 minutes, I presume it may be 500 milligrams.
Yeah, but if it is a 1
gram or something,
it'll be maximum 1 to 2 hours. That's it. By recommendation, you don't have to go more than that.
So yes, so the patient has to spend a couple of hours with you, and the patient is fine.
Slow
and
infusion,
goes off.
so we get them in a recovery, get it in, and send them home.
Right. So the next question is how much of the injectable do you give? Like do you give the entire thing? So he said maybe 1 gram, 1.5 grams.
So ferroxycarbomaltose, suppose you want to give 2 grams, suppose. Generally we never need it, but if you need 2 grams, you should not exceed 1 gram at a time. So at one given sitting, don't exceed 1 gram of ferric carboxymaltose, and then call him after a week for another one if you feel he needs more.
Right.
And then of course after 6 months you again do his levels, depending on 3 months, 6 months, depending on how you have given him. do the levels and see whether how much is ferritin risen, how much is transferrin saturation, and depending on that, again, you can decide whether he needs more or not. But one more thing, as he said, in fact, in Western countries, they give it bolus. They don't even wait for an hour. So bolus also has been given. So it's found to be relatively safe. So 30 minutes to an hour should be enough for them.
It's only our reticence to accept bolus therapies.
Right,
otherwise, there's no problem.
So
we've done it.
I'm sure there would be some discomfort which the patient might be having, or some patients might be having. So, have you noticed something like that? That some patients come with, like the usual. Earlier, we used to give iron, and people complain of
the problem was never
bone
because
pains,
the iron
back pains.
itself. The problem was that the iron moiety has to be surrounded by something to deliver it. And the present ferric carboxymaltose or sucrose is the current compounds are much easier. Those side effects are not there. So it is kind of easy. But yes, if somebody is intolerant to IV iron, you can have problems.
Anil, I had one patient where we started this and he did develop a reaction of...
yes, you can. We've all had patients.
In fact, I just came and met that patient. He was just with me about 1 hour back. He had a severe anaphylactic
Anaphylaxis is known.
Yes.
But that's a very rare thing which can happen to any
intravenous drug.
Any intravenous
So,
drug.
from what I understand, from what you experts are telling me, is that you should give on an outpatient basis, but you should not probably give it in your consulting room. You'd probably call him to
So we give it in a recovery or
in a casualty or the
A&E or
daycare or something for a couple of hours. No need to admit, just observe and then send them off.
That's right.
So now you tell me, does giving this iron therapy, does it only alleviate the symptoms, bring up the hemoglobin, or there's something more profound to it?
In fact, there are enough number of trials now. In fact, the FLAIR-HF trial, the CONFIRM trial, the EFFECT trial, which have shown that giving intravenous iron therapy not only reduces your hospitalization, frequent hospitalization, it also reduces the cardiac mortality. So there are definite hard end points where you know that there's a definite evidence in terms of benefit of reduced hospitalization. And then the soft ends, soft points which I mentioned earlier, those benefits are definitely there with intravenous.
So what do the European guidelines and the American guidelines tell us?
The European and the American guidelines do tell us that, especially the European one says in 2016 that you should give the FCM, the ferric carboxymaltose, not exceeding 1000. But the American guideline doesn't mention which one to use. It doesn't matter. Probably you could use the sucrose.
Actually, all the European data which has been collected has been on ferric carboxymaltose.
Yes, that's why.
So that's why the European guidelines only mention ferric carboxymaltose, whereas the Americans don't really stop at just at that, and some of the other compounds are reasonable.
So there are a lot of people who think still that the data is only for alleviation of symptoms and not for mortality benefit. But I think there are some new trials
there are a lot of randomized. There are some meta-analyses which have
a
couple of meta-analyses which have looked at increasing longevity and so on and so forth. But the most dominant thing has been increase in VO2 max and increase in 6-minute walk time. So that is probably the most important things which have been achieved. There are some gray areas. Gray areas are certainly which are being tested now. What about heart failure preserved ejection fraction? It's a thing where we don't have any standard treatment, where we only have to address comorbidities, and yet we don't have real data. So we now have a trial which is ongoing for HFpEF in using intravenous iron. I think that as the evidence accumulates, we would be screening a lot of our new patients with HFrEF certainly for iron deficiency.
For HFpEF also, you mean?
Yeah, maybe, but HFpEF is the problem with HFpEF. It's a very heterogeneous entity. So, and because it's a heterogeneous entity, you cannot have one-size-fits-all answers for all your patients. So maybe we need to individualize, but in the personalization, I'm quite sure that in patients who are iron deficient, even with HFpEF, it will benefit. But
I think HFpEF trial is going on, and probably once we have the result of the trial,
coming to that thing, I think mortality, I'm still not convinced. Maybe we need more data. But heart failure hospitalizations and the 6-minute walk test and clinical improvement is no question.
So heart failure mortality is very difficult for a compound which is not so old to really to assess mortality. But the meta-analyses have shown that there is an increase in lifespan. So if we are to accept it, this has not been is not been accepted by anybody as giving mortality benefit. The level of evidence, although is high, but it's a class 2 recommendation.
Right. So I think from all these discussions which we had with our expert panel, we come to the conclusion that iron deficiency is quite common in heart failure with or without anemia, and it causes a lot of symptoms and perhaps increase the mortality. It's very easy to treat them with iron, but don't treat them with oral iron, treat them with intravenous iron. You need not admit these patients for giving the intravenous iron. It's quite safe to give them in an observation room in the hospital, and you need to give either 1 or 2 doses maybe a week apart. That should be good enough. And when you do that, you are definitely going to make your patient symptomatically much better. They are going to be able to exercise much more. Their symptoms will be reduced, and perhaps their longevity will be improved. With that, I thank all of you for all your contribution to
Just
this.
remember one thing,
Yes.
that treatment of anemia does not actually improve heart failure symptoms or mortality as much as treatment of iron deficiency.
We are talking
so
of
that's
iron
that's a
deficiency.
point which,
Right.
One more thing, in acute heart failure, this iron therapy still is controversial. We do not have
that's acute heart failure, HFpEF, it is still controversial.
It's in chronic heart failure that it is used.
Yes, we have not touched acute heart failure.
Although there are trials which are actually looking at that.
Right.
Okay, thanks, Bhavesh.
Okay.
Thank
Thank
you,
you so
Bhavesh.
much. Thank you, everybody. Thanks. Thank you.